Right. Nice.
So just so you guys, so Patrick O'Connell's, he owns a Central Primary Care right over Briar Creek. So
Yep.
like one of the coolest doctors I've met, down to earth in terms of really understanding. Kind of he gets a lot of what we do here, and so we have a lot of guys your age, obviously, and this is an issue that we wanted to make sure you guys have information on, because I think no matter how much weightlifting, a lot of the right conservative stuff that you do in the gym, sometimes you're up against a hormonal block. Just that, and it also has other health implications as well too. So I thought, I know where my expertise line ends. So that's Dr. O'Connell would be a great guest to have over here, particularly with him having his practice right down the road. Hopefully a good resource for you guys.
Thanks for doing that.
Yeah.
No.
So without further ado, I'll let you take it away.
All right, great. Well, thanks, and thanks to you guys for your interest. So yeah, this is an interesting topic, huh? This gets lots of attention and lots of marketing in the supplement world. So I wanted to talk some about some of the science and what we know from a medical standpoint in terms of testosterone deficiency and supplementation and health issues, because testosterone's had an interesting career from a supplementation standpoint. So I wanted to spend some time laying some of the stuff out for you and do it in a way that's practical. Like, okay, I've got info I can take home with me based on what we talk about this evening. Now, in terms of just a little bit about me, so I'm a North Carolina native, grew up out near Winston-Salem, went to Carolina for medical school, and then up to Baltimore to Johns Hopkins Bayview for residency. Lived up in Baltimore for a few years after that, and then moved back now 13 years ago when I got married. With 4 kids and have my own practice, and I'm a general internist, so adult primary care is kind of my area of interest in practice. In terms of the practice, so Sentinel Primary Care. So I worked for Duke for 11 years before I opened up my own practice 2 years ago. So this is the practice on the website. There's me, looking like I'm offering good counsel to a fake stand-in patient for the website.
Same shirt though.
Actually, yeah, that's true. That is true. My staff sometimes make fun of me because I don't have a lot of color variation in my shirts, but anyway. And so I'm just a few miles away, so just up on the other side of Briar Creek Parkway. Okay, so before we jump into the medical stuff, I want to give you some of the background on testosterone. So the basic biology of how it works. So what you got here, so a little hard to tell, that's the brain in profile. And what we're looking at is this little area right there, which is kind of dead center in the brain. That's the pituitary gland. That's the gland that is the master regulator that tells all the different endocrine organs what to do. And the pituitary itself is under regulation from an area just above it called the hypothalamus. So the way the sequence works, and this is true for lots of hormonal systems, but for testosterone as well, the hypothalamus up in here says, I want more testosterone, sends a signal to the pituitary right there. The pituitary then produces a hormone called gonadotropin-releasing hormone that goes throughout circulation. When that hormone then gets to the testicles in response make, I said that backwards. Hypothalamus makes gonadotropin-releasing hormone. Pituitary in response makes luteinizing hormone and follicle-stimulating hormone, circulates down to the testicles, and then the testicles make testosterone. And then, interestingly, the testosterone is then sensed by the hypothalamus and by the pituitary so that the hypothalamus that started this whole thing going says, oh, I see more testosterone now, okay, I'm good. And the whole process of ramping up testosterone production kind of settles back down. So, it's all under regulation coming from the brain to the testicles, testosterone is manufactured. Make sense? Now, testosterone itself So once it has been manufactured, and then it is circulating out in circulation, so you've got testosterone. And then there's two different enzymes that act on testosterone to convert some of it to dihydrotestosterone and some of it to estradiol. So interesting, the androgens and estrogens. So guys produce some amount of estrogen coming from testosterone, kind of an interesting interrelationship between the two. But so testosterone comes out of the testicles and then down this enzyme pathway to dihydrotestosterone and down this enzyme pathway to estradiol. Now the question then is, okay, well, so what do these different hormones do? Well, so what's the main thing we think of with testosterone? It's this. It's muscles. It's Mark McGuire, who did it all naturally, I think. So this is what we think of. Now, actually, this is relevant because one of the things that I want to say is in the course of what I'm talking about this evening, I'm actually not going to talk about extraordinarily large amounts of testosterone. And I'm also not talking about folks who have congenital abnormalities in testosterone production. Those are kind of different topics. So what I'm talking about is the natural process of making testosterone and ending up with testosterone deficiency and kind of supplementation. So I'm not talking about the person who's juicing with tons of testosterone like perhaps this guy is. But so muscle is the main thing that we think of, right? Well, so interestingly, if you look at each of these different hormones, each one has its own character of the things that it does. So testosterone makes muscle. So muscle growth is under the influence of testosterone. Testosterone also influences libido, and it also influences erectile function. Now, interestingly, if you go down the dihydrotestosterone pathway, so dihydrotestosterone promotes or stimulates growth of the prostate. It is what is responsible for a lot of male pattern hair loss. And it also participates in regulating sexual hair. The other path, estradiol.
What's sexual hair? Pubic hair?
Pubic hair, yes, exactly. So estradiol, bone density. So osteoporosis in guys is a concern if a guy is testosterone deficient. But it's through the estrogen that gets the guy there. Adequate estrogen translates into less fat. It also participates in libido, interestingly. You wouldn't necessarily think of that. And it also participates to some degree in erectile function. So there's a little bit of differing flavors with the different hormones that are all interrelated to each other. Also, interestingly, some of you will know the medication finasteride, or formerly under the brand name of Proscar. So finasteride blocks the enzyme on this pathway, which is why finasteride is used for an enlarged prostate, and it's used at a lower dose to try to slow hair loss. So that's the biochemistry of why finasteride or Proscar is a medicine. Okay, now here's where we start getting into some of the interesting stuff that's going to be a little controversial, and I'm not sure I'll have definitive answers as we get to it, but this is normal biology. So with age, testosterone levels decline. And there's sort of a decade by decade predictable drop-off in testosterone such that, the guy who's 18 years old versus the guy who's 80 years old, they're going to have very different testosterone levels on average. There will be exceptions. But on average, there's going to be a very different testosterone level. This is observable kind of normal biology. We'll come back and talk about this a little bit more. Now, for guys who have low testosterone, the question is, well, why might that happen? Why could that occur? Well, here's a slide that is absurdly busy. The list of possible explanations is quite long. So there's lots of stuff that does it. And by intention, this is too small for you to read because I don't want you to be able to read it. I want you to look at it and be like, holy cow, that's a long list. There's a lot of stuff that can do it. But practically speaking, I want to look at this trio right here in the center. Because this is very relevant to low testosterone. So chronic systemic illness, opiates, and diabetes. So let me comment on these for a minute. So first off, chronic systemic illness. So normal physiology, let's say my testosterone level's here, And then I get a horrible case of pneumonia, and I'm in the hospital for 5 days. And then I go from there, and I'm home, and I'm kind of laid up in bed, half functional. It takes me a couple more weeks to finally sort of get moving again. It's a couple more weeks after that before I'm like, okay, finally I'm over that awful infection that I had. Well, if you check my testosterone halfway through that whole course of illness, where's my level going to be? It's going to be down here. So the question is why? Why is that? And the reason, if you sort of think, well, what purpose would it have for my testosterone to be lower? So it's because all the available resources that my system has, most of those resources under normal everyday life are kind of getting directed to different maintenance functions, to normal bone turnover, to normal muscle turnover, to metabolizing various things that I've eaten. It's all just sort of normal everyday activity. However, when a crisis arises, all resources go to the crisis. It's kind of like, if there's a big fire in downtown Raleigh, all of the fire departments are going to send their trucks to downtown Raleigh, right? Same kind of thing with a serious illness. All available resources go to the serious illness, and everything that can be put on hold until later gets put on hold until later, including making testosterone. Now, if you take that and look at it from a little bit different angle, you don't have to be laid up in the hospital for 5 days with pneumonia for this to start to take effect. You can see lesser degrees, but still degrees of reduction of testosterone if somebody is under lots of stress. If someone is burning their candle at both ends, they've got some huge project and they've been sleeping 5 hours a night for the past 2.5 weeks, that exhaustion, it's not the same as intensive care unit with pneumonia, but it's not totally dissimilar. And so your body starts redirecting resources towards just staying alive and taking resources away from things like making testosterone. So that's important. That's important to keep in mind. Opiates. So this one more broadly is medications. So some medicines will suppress testosterone production. Opiates are actually the sort of the best described or the most familiar. Now, if you sprain your ankle, you end up at urgent care and they give you, 10 tablets of Percocet, your testosterone's not going to change in response to that. But for the person who has everyday long-standing chronic opiate use because of, some chronic pain condition, that's a person whose testosterone production gets suppressed by the opiate. And as long as they stay on the opiate, testosterone production is suppressed. So that's an example of medications that are affecting the regulation of testosterone. And then diabetes mellitus, this kind of ties into the systemic illness one. So here the idea, just having diabetes in and of itself is not going to cause somebody's testosterone to tank, but somebody whose testosterone, or somebody whose diabetes is totally out of control, you betcha it will, because the body's redirecting all its resources to dealing with this blood sugar that's completely out of control. Testosterone gets put on the back burner. And the same is going to be true for lots of other medical conditions that have this chronic everyday impact on the person's health and well-being. Those illnesses can suppress testosterone production. Okay, useful? Questions on that?
We have a question that post-traumatic stress or long periods of stress, can that impact it?
Yeah, so great question. Post-traumatic stress and other periods of stress. So yes, it can. So that you can see a suppression of testosterone production in that case. Yep. And some of that's going to tie into how active and how much of an impact the condition may be having. So, if it's someone has post-traumatic stress disorder or depression or other conditions that are under pretty good control, not so much of an impact, versus the person who's really it's hammering them every day, then yeah, it's going to have more of an impact.
Does it usually come back, like when you get a critical illness or an infection or something like that? Does the testosterone come back after the low period?
Great question. So does the testosterone come back after you recover from the illness? And the answer is yes. Yep. And it's interesting, there's other hormone systems where you can see not just that it returns to normal, but there's actually a rebound phase, and then it settles back down. So thyroid hormone production does exactly the same thing. Person who's in the hospital with severe illness, their thyroid hormone production goes way down because the body's like, hey, I'll deal with the thyroid later. Then once they get over the illness, the thyroid stimulating hormone, which is an easily measurable blood test, surges higher than normal and then settles back down once everything is settled back to normal. So short answer is yes, it recovers. So, great question. Okay, so now let's shift. Here's what we're going to talk through. So I want to talk through, in a kind of an orderly way, the symptoms of low testosterone. When should you test for low testosterone? This is going to get really practical. How do you actually diagnose it? When should you treat it? What do you get out of treatment? What are the benefits? And what's come more to light in recent years, what are the risks? So that's an important one. We'll come to that. Okay, symptoms of low testosterone. So if testosterone drops, initially there's some quick appearing symptoms. So decreased vigor, kind of a broad category, but it's just that I don't have any energy. That can be a symptom coming from low testosterone. Lower libido, so specifically a sexual side effect. Lower mood. Again, there's 1,000 things that can make your mood not be so great, but one of the things on that list of 1,000 is low testosterone. And then erectile dysfunction, again, another sexual symptom. Now, if testosterone stays low long enough, then you get some of the more slowly developing symptoms. Most prominent in people's mind is loss of muscle mass. So obviously you're not going to lose your muscle in a week, but you can lose it in a season, for sure. And then some others, so I kind of put these under an other category. So hot flashes, infertility, gynecomastia, which is the development of breast tissue in men. So these typically occur only if testosterone is very low. I mean, very low. So, for example, a guy who develops prostate cancer and as part of his treatment is receiving testosterone blocking and testosterone suppressing medications, whose testosterone might go from a normal of, let's say his baseline was 350, and now his level is 30, that's the guy who's going to get hot flashes. Versus somebody whose level, they got sick and it's a little low, they're not going to get hot flashes from that. So these are more severe hypogonadal or low testosterone kinds of symptoms. Okay.
Are any of those symptoms treatable?
So essentially the way they get treated is you got to fix the hormonal problem that's driving it in the first place. Now some of the others like lower libido, erectile dysfunction, or lower mood, there's sort of other ways you can get at those problems where if you're not addressing the low testosterone itself, the fix may be kind of incomplete. But for some of the ones on the bottom, it's I don't have any great solutions for hot flashes for a guy whose testosterone level is super low because all of his testosterone is being blocked and suppressed for prostate cancer.
Kidney problem, you go to a nephrologist.
Mm-hmm.
I you go to an ophthalmologist. Mm-hmm. What do you go to if you got a hormone problem?
It kind of depends on the nature of it. So if it's, if there's some other condition driving the say low testosterone in this case, well, whoever can fix the underlying problem, that's the person to see, and then the testosterone fixes itself. If there's a guy who, say his testosterone's low because, he had to get radiation for a cancer treatment, and now the testicles have been injured because they were in the field of radiation. Well, so, potentially their primary care doc, potentially an endocrinologist is addressing it. But so to answer your question, so an endocrinologist is a person whose area of specialization involves abnormalities in the hormonal systems. So, although it's not always an endocrinologist you end up seeing for the sake of these kinds of symptoms. Good question. Okay, so then if these are the symptoms, so then the question is, when should I test? When is it sensible to say to my doc, can you check my testosterone? So the first thing we can say is that an approach of testing everybody, probably not such a great idea, which will make a little more sense in a second as I talk through some of the diagnostic process. But so testosterone screening, probably not a good idea. Now screening, the term means testing for something in someone for whom you don't have a reason to test for that thing. They don't have any symptoms. They don't have an indication that there's a disease that you're looking for. You're just looking. So for example, a person who comes in to see me, perfectly healthy, all is well, and I check their cholesterol level. I am screening them. I have no indication of heart disease, but I'm looking for a problem that I otherwise am not going to get an indication of so that I can do something to make them healthier over the long term. So from a screening standpoint, that's the same question. If somebody comes in and has 0 indicators that their testosterone is low, should I check their testosterone? And the answer is probably not. I'm probably going to get myself into a mess by doing that. And we'll come to the mess in a moment. Okay, so then, if we're not going to screen everybody, so when should we be targeted? And so it definitely makes sense to check testosterone for characteristic symptoms. So if a guy comes in and says, my libido is in the tank, could be a bunch of different things, but one possibility is this could be because of low testosterone, and so it's sensible to check that guy. Or similarly, if a guy has difficulty with erections, it's sensible to check him. If a guy has low bone density, like osteoporosis, that's a relatively common condition in women. It's relatively uncommon in men. So if a guy falls and has a fracture and you're like, why the heck did you break this bone? This wasn't that big of a fall, and you get a bone density measurement and you're like, holy cow, you got osteoporosis. You better go looking for the answer, and one of the answers might be low testosterone. So that's a scenario to check. Or a guy who comes in with gynecomastia, the development of breast tissue. Again, there's other possible issues that it could be from, but probably something hormonal is going on there. And so checking testosterone levels is appropriate. So these are some good, solid indicators to say we ought to check testosterone. Then there's some that are a little squishy. So non-specific symptoms, meaning, well, this could be low testosterone, or this could be 1,000 other things. So if a guy's mood is just kind of, I just don't have the pep that I used to have. Should I check his testosterone? Maybe, maybe not. Because, like I said, there's 1,000 other things that could be. Fatigue. How many of you experience fatigue? I'm fatigued when I got out of bed this morning, but I don't think it's my testosterone. I think it's because my kids had me up late last night. So, and then lower strength. So again, this gets complicated, because what if a guy is 70 and he's not quite as powerful with, say, a swing, or as fast as he was with running as what he was 20 years ago? Should I check his testosterone? I know it's going to be a little lower because he's older. Is this because of low testosterone? So it gets a little murky. It's easier with strongly suggestive symptoms. It's much harder with symptoms that could be from a bunch of other stuff. So definitely worth testing on the top list. Maybe, maybe not with the lower list. Okay, so if you've decided to test, how do you diagnose low testosterone? This is a very important question, because, unfortunately, over the years, especially earlier on in the phase of testosterone supplementation, there was a lot of seat of the pants diagnosis that maybe wasn't really carefully done. So to make the diagnosis of testosterone, you must have 2 things occur. First, you must have signs and symptoms that are at the very least suggestive, and preferably ones that are clearly associated with low testosterone. And you have to have a low testosterone, and you have to have that twice. A single low testosterone measurement is not adequate to make a diagnosis of low testosterone. You have to repeat it. You have to confirm it. And part of the reason for that is testosterone fluctuates. It goes up and down. There's a natural 24-hour cyclic rise and fall in testosterone, and because of stuff like, if I had the flu last week, that whole cycle gets thrown out of whack, so don't diagnose me with low testosterone based on a single reading when it's because I was sick last week, right? So you got to retest it, you got to confirm it. So you got to have both of those to make a good, solid diagnosis. Now, there's some technical issues with checking testosterone levels. So first off, testosterone naturally peaks around 8 o'clock in the morning, and there's kind of a plateau, and then it drops later in the day and hits the low point kind of somewhere around bedtime. And it rises again to the next morning and repeats itself. So you want to check, what's the peak? And if the peak is low, okay, maybe you're onto something. So for example, I see somebody in the office and it's 2:30 in the afternoon, and they say, like, you know, I'm having characteristic symptoms of low testosterone. And I check off the lab order, let's check your testosterone. Here's what I'm thinking in my mind. If this guy's level is low, I'm not done because it's 2:30 in the afternoon. I want to know what his testosterone is at 8 o'clock in the morning. However, I'm also thinking if this guy's testosterone level is solidly normal, I am done because I know that at 8 o'clock in the morning it was even higher. Make sense? So the time of day matters. Second, fasting matters. You get a better reading if you check fasting. A bunch of labs you don't have to fast for, but this is one of them that it's preferable to fast. And then the last one is this topic of the free testosterone. So most testosterone in circulation is bound to proteins that carry it around. They're riding on the bus, so to speak. The testosterone molecules that are biologically active are the ones that are not on the bus. They're free floating in circulation, and that's a tiny fraction of the total testosterone in your system. You can measure that tiny fraction, but the problem is it is technically very difficult to do, and apparently most laboratory methodologies are way not adequate. So if you're going to check a free testosterone, the doc who's ordering it needs to know that it's going to a lab that can actually process it optimally, because otherwise you get numbers that are just garbage. You don't know what to make of it. So that's a technical topic for the doc, but it's relevant for you guys to know about. All right, and then if the level comes back low, you're like, okay, you've got symptoms, and twice now we have confirmed you have a low testosterone. You probably ought to go a step further and ask the question, why? What's up with that? And so then it gets a little further. Luteinizing hormone, remember on that initial slide where it's like the hypothalamus tells the pituitary, tells the testicles to make testosterone. Luteinizing hormone is a signal from the pituitary to the testicles. And so if your testosterone's real low and the pituitary gland is just screaming at the testicles with a very high luteinizing level, make testosterone, and they're not responding, you have a testicular problem. If you have a very low testosterone and the pituitary gland's making like a molecule a day of luteinizing hormone, the pituitary gland isn't telling the testicles to do anything, you've got a pituitary problem. So it's sensible to take that extra step to say, why is this guy's testosterone low? And this is one of the tools that gets used to sort it out. And then there's a whole bunch of downstream stuff. But for our purposes, so signs and symptoms, gotta have it, and a confirmed low testosterone, gotta have it.
Question about
yes.
Blood versus saliva versus...
Yeah, so good question about blood testing versus saliva testing, and this comes up with other hormonal systems as well, cortisol most readily. So the best validated ways to do it, it's not the only way to do it, but the best validated way to do the hormonal testing is going to be blood-based. There's availability to do salivary testing, because one of the nice things is I can measure somebody's salivary hormone level when they're going to bed. LabCorp's closed, Quest is closed, my office is closed, but if for some reason I gotta know what a given hormone level is at 10 o'clock at night, well, how else am I gonna get it? And so folks develop salivary testing for cortisol, testosterone, and other hormones. So it's a different tool to get some numbers, but the best validated tool is still gonna be blood testing, so. Okay, so if you're thinking about treating, so assuming you've got a good, valid diagnosis. So when do you treat? When do you say, yep, give me the testosterone shots, pellets, patch, gel, whatever. So first thing to say, fix the underlying condition. If you can identify why the testosterone is low and you can fix the why, and then testosterone fixes itself. So this is obvious if the person's in the hospital with pneumonia, antibiotics will fix their testosterone. But the point is, if there's poorly controlled diabetes, for example, I can think of folks in the past I've taken care of where diabetes is really not well controlled, testosterone gets measured for some reason and it's low. It's like, wait, don't need a testosterone supplement, we need to treat your diabetes. Treat the diabetes, testosterone gets better. So fix the underlying issue if you're able to. Okay, so then let me give you some scenarios. So assuming you've fixed the underlying condition. So let me give you some scenarios, and I'm going to split it a little bit in, yeah.
What are some of the other, I mean, I know we went to the underlying conditions. How do you really know?
Yeah, sometimes it can be a little challenging. So if there's an underlying condition that's really rip-roaring out of control, it's pretty safe to say, yeah, I think this is what's driving it. Or if in the course of the diagnosis you come up with, some testicular problem or some pituitary gland issue, then you can say, all right, we've got this particular problem that's driving this. But for the kind of totally other conditions, like I keep saying pneumonia, but pneumonia, the flu, controlled, sometimes it can be a little tough to sniff out whether this identified other issue is the cause of testosterone. But one of the clues is going to be whether that underlying condition is significant enough to kind of impact the person's overall well-being, and is that underlying condition under good control or not. Those are some of the clues, but it's not always an easy process. Smart question. Okay, some scenarios, and I'm going to split it out, middle age and older age, because that's kind of where some of the research is. There's some research looking at older age, and there's some looking at middle age. Okay, so let me give you a scenario. Middle-aged man who has signs and symptoms and a clearly low testosterone level. Is this guy appropriate for supplementation? Yeah. We've got the combo. We've got the symptoms or the signs. We've got the low testosterone. And by clearly low, I mean like we confirmed it, we double-checked it, it's really low. Yeah, this is a person who's appropriate for testosterone supplementation.
What's middle-aged?
Yeah, I don't know. That's a good question.
When I was 20, 35, it's middle-aged.
Yeah, I think it's up to like 78 years old. And yeah, actually, it's funny. There's a guy, one of the folks at his primary care doc, and so a while back, he hit 75. Now, he was in pretty good health, and I wished him a happy birthday, and he said, 75 just doesn't seem so old anymore. It's like, oh, sure enough. So I say all this in jest. I actually don't have a set number in mind where I would say middle age ends and older age begins. Some of the research studies that look at older, I have to go back to the methodology, but it's going to be like 60s or 70s and up. So certainly for research methodology, 70s would certainly get a guy into the older category for purposes of thinking about testosterone. Okay, so how about older men? Let's say we've got a guy who has signs and symptoms. He has difficulty with erections. Check his testosterone, it's low. We recheck his testosterone, it's low. We can't come up with some other explanation, but in the course of investigation, we realize like this guy's got testicular disease or he's got a pituitary gland disease, and that's what's causing this. Is this guy appropriate for treatment? So this guy would be, because we've got the combo. We've got a good solid diagnosis. We've got symptoms attributable to low testosterone. We've got low testosterone, and there's not some thing we can fix that would thereby fix the testosterone. So this would be an appropriate person for supplementation. So now what about, let's say, again, an older man who has signs and symptoms. So he's got difficulty with erections, let's say, maybe loss of muscle mass. He has a clearly low testosterone, but the only thing you can come up with is that he's older. Should you treat him? This is a mess. Yes.
My youngest girlfriend is.
There you go. So this is where, that's this slide, the biology of testosterone is that decade by decade, the level of normal declines. So what happens when a guy has some symptoms and he's in his 70s and you're like, hey, your testosterone's down here, it's kind of low. But you kind of look around, you can't find anything else that's driving the low testosterone, and you end up saying, I think this is just because you're in your 70s. Should you treat this guy? And the answer is, I don't know. Maybe, maybe not. This is a very gray area. Now, if I work in a clinic where I make money off of administering testosterone, then clearly this guy needs treatment. Versus if I'm his primary care doc, I'm like, meh. Yeah, you're fine. You're in your 70s. So this is a gray area, and there is differing practice, and there has been no end of arguing and ink and whatever, professional journal articles back and forth on this exact topic. Now we're going to come to, yes?
Question about, say, the 70s, yeah, you're not really sure.
Uh-huh.
The reason you're not sure, would that be because of side effects at a certain age versus side effects at a different age?
Yeah, that's a little bit of it. Yeah, side effects is part of it, but the other part of it is this still kind of uncertain topic that, you know, if a 20-year-old has symptoms attributable to low testosterone and his testosterone level is down here, it's like, woo, that low testosterone is causing those symptoms. The guy who's 70 and has exactly the same symptoms and his testosterone is here, the question is this testosterone actually the explanation for these symptoms? And it may not be. That's part. So it's both like there's some risk that goes with the testosterone, but is there benefit? Not clear. So, yes, ma'am.
What is the risk?
Yeah, we'll come to that in a sec. Anyway, yeah, we'll come to it in a sec. So, but this is where it gets tough because the natural process is a lowering testosterone over years, over decades, and then some uncertainty about trying to figure out is this low testosterone attributable to age and therefore causing something or not causing something, and it gets really murky and it gets really tough. So that's why I leave that with a question mark. I don't have a definitive answer on that. Now, how about another scenario, older man again, he's got signs and symptoms, let's say, so difficulty with erection, loss of muscle mass, whatever, lower libido, or he has a low testosterone. So let's say, so first one would be the guy comes in and says like, yeah, gosh, I'm not as fast as I used to be, my muscles are wasting away, I have difficulty with erections, I checked his testosterone and it's squarely in the middle of the normal range. Should I give him testosterone supplement? Or if I happened to screen a guy for testosterone, comes in for his checkup, I'm like, hey, how you feeling? Great. How's your sports going? Whatever sport you play. He's like, that's great. I've set my record last week. Like, hey, how are things with your wife? Great. And I check his testosterone and his level's low. Should I treat him? So essentially, it's a way of saying, if the guy looks like this, doggone it, don't give him any testosterone. The point is, remember what we need to make a diagnosis. You got to have symptoms that you can blame on low testosterone, and then you got to have a low testosterone. If you don't have both, I better keep the prescription pad in my pocket because I'm not going to be helping, and I'm going to open the door to some potential side effects. All right, same thing. Middle-aged man, vague signs and symptoms. Like, I just don't have as much pep as I used to. I'm like, well, difficulty with erections? No. How's your libido? It's fine. I'm like, I just don't have as much energy. And I test him, and his level comes back low. Should I treat him? Problem is, I didn't confirm his level. So no, I better keep the prescription pad in my pocket, because I actually haven't diagnosed him with low testosterone yet. All right, all that makes sense? All right. I'm going to keep sliding over so I stay out of the sunbeam here. Okay, so let's now talk a little bit about benefits of treatment. So you've made a good diagnosis. You're solid in the diagnosis, appropriate symptoms, you check the testosterone, it's low, you recheck it, it's still low, you look around for other causes, you fix whatever you can fix, still you got the issue. So you say, all right, it's time, let's start testosterone. What are you going to get out of it? What are the benefits? So, again, I'm going to break it down. Middle-aged men and older men. So middle-aged men can expect improvement in libido. Middle-aged man can expect improvement in erectile dysfunction. He can expect an improvement in muscle mass. And again, I'm not talking Mark McGuire. I'm talking a guy who has low testosterone and has lost muscle mass because of it. He can expect his muscle mass to improve. And he should expect his bone density to get better as well. I've never measured his bone density, but it's going to get better. I'm not going to know it, but it'll get better. And maybe his mood gets better. There's conflicting data on this. Okay, how about older men? What can men expect? So this is helpful. There was, I think it was I think it was 2018, maybe late 2017, there was a group of several studies run in parallel with each other, all in older men, trying to get at this question, because people have been arguing over this for years. And so very helpful studies. So what can an older man expect in terms of benefit from testosterone supplementation? So one, libido and erectile dysfunction, a small improvement. So when researchers use standardized, careful methodology, they see improvement, but it's not whopping improvement. Energy level, probably a small improvement. Again, not a rip-roaring, humongous improvement, but there's probably something there, probably some benefit. Mood, probably better. Don't you love all this hedging? It's like, come on guys, can't you researchers give us a clear answer on this? But when they use different tools to assess in these studies, mood, yeah, is a little better on some measures, not better on other measures. Physical performance. Gosh, I wish we had better data on this one. Researchers over the years have done things like measure the squeeze force you can generate. Like, yeah, that's nice if you're a researcher, like that's an easy to measure thing, but dude, I need more useful information than that. Than like, okay, great, I'm glad I'm on testosterone. Like, no, I need something more applicable. They've done things like leg press strength. Like, yeah, all right, that's helpful. But it didn't tell me what I really want to know, does it? It doesn't tell me, am I going to be a better athlete? Am I going to be able to avoid injuries? Am I going to be able to get back to a prior performance level? I don't know. Hasn't actually been a direct topic of research or a measured outcome. But in this parallel set of studies that were done, that were finished about a year ago, they looked at the 6-minute walk test. So that's a standard assessment tool for kind of overall physical function in somebody who's not an athlete. How far can you walk in 6 minutes? And so, maybe there was some improvement. Again, not tremendous. And again, I hate all this equivocal stuff. I mean, researchers are like, well, it's kind of better. Cognition. So this is an important one, because cognition gets promoted as a benefit of testosterone, and it doesn't make a difference. You're not going to prevent Alzheimer's through testosterone. You're not going to make yourself smarter. You're not going to make your brain work faster through testosterone supplementation. It just didn't work. So that's one, we have definitive data. So kind of big picture, the symptoms that are most characteristic of low testosterone, libido and erectile function, those are the ones that get better. Again, it's not a huge success, but at least they get better, as opposed to stuff like, well, your cognition's not going to get any better. So this is what you get out of it as an older man on testosterone supplementation. Okay, now let's talk about risks. So this is an area where folks have really started to dig in recent years and get more information. I remember, so one of the guys, when I was back in my residency training up in Baltimore, one of the guys who was one of the endocrinology sort of professors there, he, a number of years later, authored a study that was a small study. It was looking at testosterone supplementation, and they were looking at something like grip strength. I'm like, woohoo! But that was the first study, that, at least that I'm aware of, that showed a small increase in heart attacks. And it was a small study, so it's like, yeah, how much am I going to believe this? But everybody's like, whoa, heart attacks, hang on now. So then after that, researchers said, all right, we got to dig more into this one. So let's talk about the risks of testosterone supplementation. So first off, if you're taking all the testosterone that you need, your testicles are like, hey man, I'm going on vacation. I don't have anything to do. And if you then stop testosterone supplementation, it may take a while before the testes can get back into business making testosterone. So they can recover. If somebody uses lots of testosterone, like performance enhancing, they may not. So that's one. Second, erythrocytosis. You'll make more red blood cells. Yeah, this is one where I can't get that excited about it. Like, yeah, as the doc, I'll check the red blood cell level. But if I'm the guy contemplating testosterone, I'm not losing sleep over this one. Prostate cancer, maybe. Theoretically, it makes sense, because we know that guys get prostate cancer if you cut off the testosterone. The most of the time, the cancer will stabilize or regress. So people say, well, doggone it, is testosterone going to cause prostate cancer? And it's actually not clear. It's theoretical, but it's not clearly the case. Prostate enlargement, same thing. Not clear. Theoretically, it makes a lot of sense to me, but it hasn't been definitely proven that it will. Sleep apnea, again, this is like snoring pushed a step further, so you're laying in bed, you're snoring, and then the back of your throat just completely closes off, and you stop breathing. So that may get a little worse with testosterone supplementation, maybe. Heart disease. So this is the big one. This scares everybody, right? So here's the study. Here's the data that we have on this. The first one I told you about is this very small study where there were a couple of extra heart attacks, not statistically enough for us to say, whoa, that's it, we're done with testosterone. But in these several parallel studies from last year, they specifically looked at surrogate markers. The studies were not long enough or big enough to measure heart attacks. You have to have a big study go on for a long time to be able to do that. But what they did look at was the thickness of plaques in the carotid arteries based on CAT scanning. And the plaques got thicker in the guys taking testosterone. Whew, that's scary. So that makes me nervous because I have patients who die of heart attacks. I have people I take care of who die because they have a heart attack. So when heart attack comes onto the list of potential side effects, I get really jittery. So this, to me, this is a legitimate concern that I think should give everybody a little bit of pause before they jump on the testosterone bandwagon. Now, so what that boils down to then, and again, like I said, it's not definitively proven because the study would have to be huge or much longer, but the info that we have raises serious concern. So again, if we put this whole thing together, so starting off, we talked about symptoms. You want to make sure you've got some symptoms or a good reason to test. If you test, you want to make sure that you make a diagnosis on a good, solid footing so that you're not invoking risk for no good reason. So you make a good, solid diagnosis. We talked about scenarios when to treat and maybe scenarios when not to get so excited about treatment, which ties into the likelihood of benefit and the kinds of benefit, and then the risks that you're going to bring on yourself with supplemental testosterone. All that makes sense. All right. I'm going to do a little parallel track here for the last minute or so. That's what I just said. So what about over-the-counter supplements?
Eugenics.
There you go. So here you go. This is a Google search. So this is all like herbal stuff. This isn't actual hormones. But so if you would like to view yourself as a bull ready for the running of the bulls, you have Prime Test. If you would like to view yourself as a buck ready for mating season, you have Rut. If, however, you are more into the organic and natural, you have Herbal Tea. So there are lots of supplements. Now the question is, any of the stuff work? No. None of it works. It's all garbage. You look at the ingredients, most of it is vitamins and minerals, and then usually some proprietary blend of, this herb and that tree bark and stuff like that. None of it is validated to do anything for your testosterone, so save your money because this stuff's expensive.
Can any of this stuff be dangerous?
Yes, absolutely. So now most vitamins, I'll take it from that angle because that's where we have some research. So most vitamins are fairly innocuous. If you take too much, whatever. Take too much vitamin C, I'll just pee it out. If you take too much vitamin A, for example, and you're a smoker, you'll increase your risk of lung cancer. If you take too much calcium, you'll increase your risk of kidney stones. So there are some downsides to supplements and vitamins. Some stuff interacts, some herbal supplements, like St. John's wort, for example, effective for mild depression, but it interacts with a bunch of other medications. So all of these things have the potential to cause side effects. And then this one, what about DHEA? So this is an adrenal gland produced androgen, and it's in a lot of supplements. You can get this off the shelf. So this one, I click next and nothing's going to come up because we actually don't have very much research on this. So there you go. What about DHA? I don't know. There's not enough that we know about it for me to give you good take-home messages on it. I'd be a little leery though, just because. All right. Thank you very much. Questions?
What are kind of a couple of So when you do prescribe, what do you prescribe?
So, meaning like...
For testosterone. If somebody, you diagnose somebody who can you benefit from it, what are some of the things that you can prescribe?
Do you mean like the formulations of it? Yeah. So one thing with testosterone, it's not... Oh, yeah, sorry, thank you. So the question would be, what formulations of testosterone would I prescribe when treating? So first off, you can't take testosterone as a pill because, so like estrogen and hormone replacement for women, take it as a pill. And you can get it other ways, but you take it as a pill very commonly. Guys, you can't do that with testosterone. The reason is, something you eat goes to your stomach, intestinal tract, gets absorbed, and then it goes to the liver, and the liver processes it. And testosterone hitting the liver is bad. So you got to bypass the digestive tract to supplement testosterone. So that's why there's all these crazy ways of giving testosterone. There's topical, so like patches, gels. Is there? I can't remember if there's a spray. There might be, or injections, or like these slow dissolving pellets that the urologist will inject. So all of it's got to bypass the digestive system in order to give testosterone. So like when I'm the one who's prescribing it, like I don't have the tools in the office to do the pellets that get injected into the rear end. Most guys aren't that crazy about that anyway. So usually I'm doing topical, so patches or gels.
How long do you take it for?
That's a good question. So the question is, how long do you take the testosterone for? And it depends on the underlying reason that you're taking it. So if it's, in principle, if it's something intermediate term and the underlying thing is reversible, then you could take it just for the intermediate term. If it's going to be a permanent issue, and some folks end up on it long term. Yeah, so like one fella from a number of years ago, he had, I can't remember what caused it, but he had injury to the pituitary gland. So his pituitary was unable to tell the testicles to make testosterone, so he was on testosterone permanently. So it depends on the underlying trigger to be on treatment in the first place.
During testing, you talked about the pituitary. How do you know if it's a pituitary?
Yeah, so the way you would figure it out is if you have low testosterone, you see it again, low testosterone the second time, and then you test the luteinizing hormone, the LH. That's the hormone communicating signal being released by the pituitary to the testicles. If that level is very low and the testosterone is low, it tells you the problem's going on up in the regulatory system in the brain.
Different treatment, it's even treatable, right?
Yeah, so then you think, well, so you can see that if someone is really sick with something else, because the brain's like, I'm making testosterone, I'll worry about that later, so the luteinizing hormone goes down appropriately. But if a person has something going on in the brain, so you got a tumor, you've had a traumatic brain injury that's damaged the pituitary, for example, then as you go looking for what that underlying thing is, like you may end up doing an MRI, for example, and discover like, oh gosh, you have this mechanical issue, you've got a growth, you've got a cyst, you've got a tumor that's compressing the part of the brain that would be regulating this whole system. Yeah, good question.
Is there any, like if somebody, I'm assuming that the normal levels for a person are individual. So would there be any reason to test in 20, 30, like have there been any studies that have looked at like what's the normal drop?
So, as far as I know, it's largely based on population studies. So, which means you take a bunch of 20-year-olds and a bunch of 30-year-olds and a bunch of 40-year-olds, and you see this grouped average drop-off. I don't know of any longitudinal studies that have looked at individuals to see what their testosterone levels do, to see if there's a consistent decline from one individual to the next. As far as I know, it's all based on population studies. Because then that raises the question, well, yeah, that's great for populations. What about my testosterone level?
Right,
and it's
so
like,
the younger guys, like, would it be good to just test it now, just to have it?
Right.
Test it again when you're 40. And then if that never did happen, you'd have prior norms.
Right. Yeah, and so in principle, that makes sense. So the idea was if you had checked levels when you were younger so that you could kind of track it over time, would that information be useful to be able to look back at later? But the problem is, since we don't know on an individual basis what the individual ought to do, would be hard to interpret it.
So what I'm taking away from this is that you have low T, for whatever the reasons are, pituitary or something else in the testicles. getting a testosterone supplement is not the answer. You know, that's going to increase your heart problem.
Yeah.
So you're left with not a solution. So let's say you go down the path and you have low testosterone. What's the word? I mean, you know, having heart disease, you could die.
Right.
You have low testosterone.
Then you just want to die.
You get
Sorry. Well, so smart question. So the couple things I'd say. So one is I realize like I'm putting a little bit of a wet blanket on testosterone, but there are definitely scenarios when testosterone supplements are totally appropriate. So part of what I'm offering is the counterweight to, for many years, you know, the age clinics, like we'll keep you young forever. Like, oh, your testosterone's less than 1,000, you know, that would be way high. You need supplementation, and you know, it's like, hey, I'm in the business of giving testosterone, so guess what? I'm giving you testosterone. Like, yeah, that's not such a smart idea. But for the person who's got a legitimate reason, they really do have an issue coming from low testosterone, and you've confirmed they really do have low testosterone. It's appropriate to give it in that setting. Now, for part of the issue with the risks that go with it, like heart disease, for example, so then you get into more of the technical issues subsequent, like you say, okay, let's start this dose. You want to come back later and make sure that's the right dose. And what you do is you recheck testosterone level. Because like normal, it's going to vary from one lab to another, but normal may be something like, let's say, 200 to 800 is the normal range for a given lab. And I get somebody in their levels low and I start a supplement. Well, if I shoot them up to 999, that's too high of a dose. I got to cut back because I'm probably, I don't know for sure, but I'm probably going to drive their heart disease risk more than if I only got them up to like 275. They're up in the normal range, but they're not way high. Then that's probably a safer level than jacking it up too high. Does that make sense?
Yeah, you're reducing the heart disease risk.
Yeah.
By giving them less testosterone.
Yeah, by kind of giving a more physiologically appropriate dose.
When you say testosterone,
yep.
you're also considering the estrogen part as well.
Yeah, so the estrogen doesn't get measured, but we know that because of the enzyme activity in normal guys, that some of this testosterone is going to get converted to estradiol. Yes.
Okay. So if a guy has high estrogen, so I had somebody who had that, is that a testosterone? What's that?
There's probably, that sounds like somebody you should see an endocrinologist. Yeah. There's probably something more going on there that would need a little sorting out. So.
When you test,
yeah.
I think you go to your annual physical, or you're going to go in for surgery where they do all the blood work. Is that one of the things that they would test for automatically, or would they look at that automatically or not? Yeah,
for surgery, no. For an annual physical, probably not. I mean, some folks will test it. Some docs will check it, but I would say by and large, most don't. Most wait for symptoms to trigger the check, but most probably are not checking it just as a matter of routine.
And are there any, I've heard in different fitness circles of heavy lifting, like lifting weights and nutrition and other medicinal ways to increase testosterone. Is there any studies or anything behind that?
So I don't know that any of that actually boosts testosterone. I mean, it certainly boosts muscle mass for sure. I don't know that any of that will affect the natural set point of a person's testosterone. It might, but I don't know of any research to say yes or no to that.
So maybe more just case by case.
Right. Yeah. Yeah. Yes.
If your only symptom is fatigue, would you be likely to?
I'd look for other things first, and if I can't find anything else, then maybe I would check testosterone. And then if it turns up low and we confirm it's low, I'd kind of come into it with some trepidation. So I'd have the conversation and be like, so this might help, this might not, here's some potential downsides. So in conversation with a guy, if we said, yeah, let's give it a shot, I would also say, and let's reassess. If we're 3 months down the road and the guy says, I don't know, I'm just not any better, we're done, get rid of the testosterone. Because that wasn't the cause, that wasn't what was causing the fatigue. Versus if the guy's like, oh my gosh, silver bullet. Okay, all right, maybe we were onto something then. Yeah, so I would reassess rather than just pull the trigger on it and never think about it again.
In the case of one of the other symptoms of gynecomastia,
Mm-hmm.
is it when you take the testosterone, did that get rid of the breast tissue?
Yeah, so in that case, if, now again, this would apply to guys who have an extremely low testosterone, which is an unusual circumstance, often driven by other medications as a side effect. But yeah, in principle, if you fix all the hormonal craziness that caused the gynecomastia in the first place, then the gynecomastia ought to reverse.
So they get rid of the breast tissue?
Yeah, yeah. So as an example, there's a blood pressure medication called spironolactone. Yeah. So with spironolactone, great blood pressure medicine, but biochemically it can attach to or partially attach to some of the hormone receptors and trick the body into thinking hormone levels are other than what they are, and some guys will develop breast tissue as a consequence. The spironolactone, and I tell them, like, yeah, it's probably going to take 3 to 6 months, but it ought to get better, and it typically does. So that's an example where messing around with the hormones or the hormone receptors causes the gynecomastia, and then stopping the hormonal abnormalities, and it reverses.
Any other questions?
All right.
I really appreciate
Yeah. Thank you very much.